Let me share the screen. Okay. So I was saying earlier that the significance of the hemorrhage depends on three things. It depends on the volume of blood that is lost. It depends on the rate of blood loss, and it also depends on the site. Okay, so let's look at these things one by one. So when you lose about 20% of your blood volume, you can go into shock. And so if you have, let's say, a road traffic accident, which causes massive bleeding from the femoral artery, you can go into shock. Okay, so it can result in hypovolemic shock. We'll look at shock session. Now, the size of the bleeding or the size of the hemorrhage is also important. If you have bleeding in the subcutaneous tissue, that is under the skin, that's really no big deal. But if you bleed into your brain, the same amount that you bleed in the subcutaneous tissue can be fatal. Okay. Now, the bleeding also depends on whether the bleeding is internal or external. The effect of it or the clinical significance. If you have internal bleeding, the iron is stored in the liver and it can be used for production of new red blood cells. But if you have external bleeding, that is, you have a cut on your hand and the blood is just pouring out, you're losing that blood. Or if you have heavy menstrual flow and there's excessive menstrual bleeding, you're losing that blood. And so that consequence of the loss of the blood will be heavily felt. As in the patient, you become anemic. But if the bleeding is internal and it is not fatal, that iron can be sent to the liver and will help with the synthesis of new red blood cells once your bone marrow is very active. Okay, so that's the end. Sorry. All right, so
yes, madam, a question.
clinically significant, so I'm sure there'll be a lot of questions. Yes, please ask your question.
Oh, okay. The last point you made concerning, let's say, bleeding heavily during your menstrual flow. I thought that the menstrual flow is as a result of the egg which has not been fertilized, so it has to come out.
So let me share a
You
joke.
lie. Hey.
Funny enough, funny enough, apparently, a lot of people have this this perception. I didn't know. I mean,
Madam, I'm a Ghanist. Let me sort him out.
It has reminded me of something funny, but I will not share it. Let me
Please say it.
Don't say it.
Madam, please. This is adult class, oh, madam. Adult class.
Look, share it.
Sharing is caring. Sharing is caring.
Let me explain it. Maybe when I finish explaining, I'll think about it whether I want to share it or not.
Oh, sharing is
So,
caring.
in physiology, let me explain something that happens physiologically.
Okay.
So, physiologically, a woman's menstrual cycle is cyclical and is under the control of hormones. So let's say ovulation. So ovulation is controlled by hormones. So when the hormones are released, it causes the egg. The eggs are present from birth, but every month one of them is matured under hormonal stimulation. And so during the cycle of the woman, there's a hormone called luteinizing hormone. This luteinizing hormone causes one egg to mature every month. So at the ovulation peak, this hormone level shoots up, and that's what we call the LH surge or luteinizing hormone surge. This hormone would cause the egg to mature and be released. So that's the ovulation. Now the egg is matured, it's released, it's in the woman's reproductive tract. either in the fallopian tube or just around the fallopian tube. If there's sexual intercourse and a sperm manages to fertilize this egg, then it will be embedded in the uterus and a fetus will be formed. However, if there is no fertilization, this egg, within 72 hours of its release, it will disintegrate. Now, the egg is microscopic. Okay, the semen is also microscopic. So the egg is not the blood that is that is released. So people have that impression, say, what Kosiana, yeah, fertilizing Kosiana pie, no, that is not what happened. So the egg is entirely microscopic, okay, and so is the sperm. What you see when a man ejaculates is not the sperm, it is semen. Semen is fluid which contains the sperm. It contains fluid, it contains nutrients that nourish the sperm. But the sperm is microscopic, and so is the egg. Now, the egg can stay in the uterus, in the fallopian tube, for up to 72 hours. If no sperm comes to fertilize it, it will disintegrate, and that's it. So what causes the menses? Good question. So after the LH surge, when there is no fertilization, it sends hormonal signals, and you have
who is that? We are listening.
It causes a drop in the level of the luteinizing hormone, and this would lead to a drop in the level of estrogen and progesterone. So remember that whilst the egg is released, there's also preparation going on in the uterus to cushion the uterus for implantation of a fertilized egg. So this cushioning is in the form of rich blood vessels and thickened endothelial lining. The lining becomes thicker. There's fertilization. That embryo would be well embedded, and it will be taking its nutrient supply from that rich blood vessel until the placenta is formed for that take over that function. Okay? So this rich blood vessel lining is within the endometrium of the uterus, and so if fertilization doesn't occur, then what will happen is that this hormonal, then if fertilization doesn't occur, there's a decrease in the level of LH with a consequent decrease in the level of estrogen and progesterone. Progesterone is one of the main hormones that sustains the uterine lining. Once the hormonal level drops, the uterine lining is no longer being supported, and so it will be shed. It will be shed, okay? So when it is shed, that blood thickened endometrium with rich blood supply would integrate, and it will pass out as blood. I hope you understand.
So, madam, if I get you clear,
The hormonal, it is the effect. So they say that menstruation is a sign of disappointed uterus, basically, and it's a hormonal effect. Yes.
Madam, if I should get you clear, does it mean that the menstrual that blood that comes out is the shedding of the endothelium of the uterus? That is the basic, like the endothelium, yes. The shedding of
endometrium, not endothelium. Endothelium is the blood vessel wall.
Okay.
Endometrium is the inner
endometrium.
Lining. Yes.
Oh,
yes.
Okay. So when the endothelium or whatever is shed off.
Endometrium.
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 Ebedio.
Endometrium. Say me can say obi rate to me fit the index number. Me can say we. That's how you see bad day. So see am good.
So you were
Madam, so what accounts for?
Where are science? So where are science? Endometrium.
Madam, can you-
Jeff, you have a question. Go ahead.
Yeah, I was saying that what accounts for the heavy flow, because obviously some will be experiencing lesser flow than others. So what stimulates the endometrium to release such amounts of blood that will go beyond and then will come to the hemorrhoid?
You remember I said that the endometrium lining is maintained by progesterone. You remember?
Yes, madam.
Okay, so two things can happen. Either there's excessive hormonal stimulation, which causes excessive buildup of the endometrium. So the thicker the endometrium lining, the more the blood that will be lost when it is shed. So either there's excessive hormonal stimulation or there's excessive thickening of the endometrium, both of which would lead to excessive bleeding.
Jeff, if you can answer why Nat's head is bigger than mine, I think you can answer this question yourself.
Okay, then let me explain something. I just remembered something as well. So you remember that sometimes those of you who have female babies, or well, not really, you don't really need to have a female child, but if you ever come across a situation whereby somebody says that a newborn baby girl is bleeding vaginally, this is also a reason why it happens. So you remember I was saying that during the menstrual cycle, the bleeding occurs because of decreased levels of estrogen and progesterone. If you remember. Now, whilst the baby is in utero, there are high levels of estrogen and progesterone in the mother's blood, which come to the baby from the placenta. So the baby will be exposed to these increased levels of estrogen and progesterone. Once the baby is born, the levels of estrogen and progesterone are no longer coming in from the mother. And so the levels will drop in the baby's blood. That can lead to bleeding from the uterus of the baby. And you will see small blood in the vagina.
The boss's wife, your microphone.
So this is as a result, it's similar to what happens during menstruation. So if you ever encounter that a child is bleeding, or somebody says, oh, there was some small blood in the diaper and it's a female, don't be worried. It's a physiological thing. It doesn't last long. Usually within 24 hours, you don't see it. And it's very, very small and nothing to be worried about.
Okay, thank you very much.
Okay. Any other questions?
Madam, you said you were explaining something to us.
Oh, my hand is up. My hand is up for like an hour now.
Explain what to you?
The renin angiotensin.
You remember something?
You want your story?
So friendly. My husband also had the same opinion or impression about the egg. And it came up, and so I have had a BTL. That's it. My tubes have been tied. I can't have any more kids. And he was like, so if I can't have any more kids and my tubes have been tied and the egg is supposed to pass through the tube, why do I still have an egg? Because if the egg can't pass through the tube, why am I still bleeding? I'm like, what has it got to, isn't it the egg that
Kosia.
Breaks and then the blood comes. So if the egg doesn't count pass through the tube, how come you are still bleeding? You know, it was so funny that day.
Madam. So, madam, where does the blood pass then? If you have locked the uterus, you have the opening of the uterus. Because I had wanted to ask that question.
No.
You haven't blocked it.
No, if you have a BTL, it's bilateral tubal ligation. Find your tubes. Is a tube.
You people are not madam. Keep quiet. Yeah, madam.
Madam, you want more fashion? Why?
The uterus is the womb. Okay. And from the uterus, the exit of the uterus is the vagina. Okay. So the blood from the uterus will pass to the vagina and come out. But if you block your tubes, that's where the egg will pass through. And you block that.
Madam, the tube you are talking about, they don't know.
You don't know. You do know. Do you know?
Fallopian tube.
John Boy, do you know?
It's very bad. Hey, I'm not
Madam.
Yes, Christian, you had a question. Yes.
Yes, madam. Thank you very much. I have a couple of questions. The first one is about spotting. So why, if the embryo is formed, what then is the physiology behind the spotting that comes after pregnancy or conception?
Okay,
and the ladies that have menses throughout their pregnancy.
Okay, so let me explain that. So usually when the egg is fertilized and the embryo starts dividing, when it comes to settle in the uterus, it tries to invade into so that it can supply. And that is what causes the bleeding. We call it implantation bleeding. Okay, so that causes slight bleeding when implantation occurs. That one is normal in some women. Now, for those who continue bleeding during the pregnancy, it's either there is a threatened abortion, there's a threat of the child being lost, or there's some hormonal imbalance. So maybe the levels of progesterone decrease, and you know that it's the progesterone that maintains the uterine lining. So if the levels of progesterone decrease, then you have bleeding. And so you realize that the gynecologist will give you progesterone tablets or progesterone suppositories to insert to sort of control this bleeding and to stabilize the pregnancy. Okay, next question.
Madam, okay, so the next question too is about ACG. You see that after pregnancy, the human corticotroph gonadotropin is being secreted. In as much as during testing, we look out for that within the urine. Why is it that sometimes certain ladies would be pregnant for 2 months, yes, still we can't detect, but yes, still the pregnancy will be there? What causes that? Because it made me sometime.
Okay, so what happens is that if you use urine, it takes a long time for the levels to build up for you to test it in the urine. But if you use the blood, it's better. So usually for the early pregnancies, the level of the HCG increases gradually with time. And so for some, if the levels are small, you may not detect it in the urine because you have to have high levels in the blood before it would be excreted in the urine. If the levels are low in the blood, you will not find it in the urine. However, once you test the blood, you will find it, and then you realize that. So usually the gynecologist would request beta HCG of the blood rather than the urine. So that's the reason.
Madam, the final one is on what you just explained concerning family planning methods.
We are not talking family planning. You go on with your question.
Madam, you see that from the anterior pituitary gland, it sends signal to the target cells, i.e. the ovaries and the estrogens and kind of stuff. So during family planning, there is no signaling in that. I don't know how during family planning, eggs are not produced. So that means physiologically, if eggs are not produced, or maybe signal is not being sent to the target cell, that means there is no endometrium going to be formed. So then that means during family planning, there is no menstruation going to be seen. Is that what?
Well, so we can't say it's a blanket statement like that, because it depends on the type of family planning. Okay, I just said that if you do a tubal ligation, you still have your menses. Okay, so each family planning method depends. Each family planning method has its own mechanism of action. So if you take, so let me give a few examples. If you take the pill, the pill acts by producing estrogen. The pill contains estrogen and progesterone. Now, what this estrogen and progesterone does is that if you take it daily, it increases the level of estrogen and progesterone in the body. And so you realize that once the estrogen and progesterone levels are high, the anterior pituitary will not produce luteinizing hormone. Okay. If you remember from what I said earlier, it's a luteinizing hormone that causes the egg to mature and to be released for ovulation to occur. Okay. So if there are always high levels of estrogen and progesterone in the body, the luteinizing hormone will not be released and the woman will not ovulate. And so once there's no egg, there will be no. When you look at the pill, it has a set of 28, but 21 of them are the estrogen progesterone combination, and then 7 of them are just iron tablets. So when you take the full dose, what happens is that when you get to the iron tablets, because it's not estrogen and progesterone, it will cause the levels of estrogen and progesterone to go down. And once you have this withdrawal, this lowered levels of estrogen and progesterone, the woman will bleed and have her menses. I hope you understand. So
yes,
if you are
thank you, madam.
taking a pill, you still have your menses. Okay, let's look at another example. If you are on the IUD, you insert it into the uterus. It doesn't interfere with anything. It is just there preventing implantation. And it is also causing a chemical reaction in the uterus such that when the sperms pass through on their way to get to the egg to fertilize, it causes an inflammatory reaction, and so it kills them and they are not able to get to the egg to fertilize. Okay, so that one too is a different mechanism altogether. You get it? But something like the implants, because it has high levels of progesterone which are maintained. So you realize that maybe when people are put on the implant, which is put in the arm, they don't bleed. Maybe 4 months, 6 months, they don't bleed. Then once in a while, they have some small spotting. Okay. So each type of family planning and how it works. And of course, you know that the diaphragm, the female condom, the male condom, they are barriers. So it doesn't prevent anything. It just prevents the sperms from entering and causing fertilization.
Madam, my last question. My last question is
Massa.
last one.
Questions now besides so, and they are not.
This has been out for a long
Family
time.
planning is
Tell how now debate it here.
Yes.
family planning as
Kofi AJ, please ask your question.
No, Christian, you finish your questions. I think
Okay,
we have
okay.
some.
Madam, so please, in menstrual pains,
Charlie, your time is going. No, your time. This is the second session.
What has menstrual pain done?
Madam, I'm done, boys. Thank you, madam. They won't allow me to talk. Okay, madam. So, madam, during menstrual pains, a two-in-one question. What causes the menstrual pains? What causes the pains within the abdominal region? And is it advisable to recommend family planning methods that would cease or reduce menstruation to a patient? To a lady who is really suffering from menstrual pains, in as much she's not ready to give birth or not ready to marry. Would it be advisable to recommend a form of
menstrual pains are as a result of prostaglandin production, and that's what causes the uterine contraction and the subsequent pain. So some gynecologists recommend, usually it's from hormonal imbalance. So some gynecologists can put you on the pill, for example, to help regularize the hormonal levels. But it's mostly has to do with the gynecologist, what their opinion is. But you can't just say that because they have pain, they should be on a family planning method. It depends on what's causing the pain. Sometimes the pain can be from PI, pelvic inflammatory disease.
Through disease.
So that leads to congestion during their menses and they have pain. So depending on what is causing the pain, then you recommend adequate treatment. Is any other question?
Yes, madam. Kofi AJ's hand is up for a long time, and then there's another question in the chat. So I think we should answer those two.
Please ask your questions.
Kofi, Ajay, please unmute your microphone.
Hello.
Yes, ask your question.
Madam, it has to do with the renin-angiotensin aldosterone, about how it also helps in the retention of fluid. You said you explained, so.
Okay, so I was saying that is physiology. So what happens is that, you know, the juxtaglomerular apparatus, it's in the kidneys, it's in the renal tubules. Do you know the renal tubules?
Yes, madam.
Yes, madam.
Okay, so you have a system called the juxtaglomerular apparatus. It senses the volume of blood that comes to the kidneys. So if you have a situation whereby there's little blood entering the kidneys, that juxtaglomerular apparatus is activated and it secretes a hormone called renin. This renin would lead to the production of angiotensin 1, angiotensin 2, and then subsequently production of aldosterone. What the aldosterone will do is to go to the collecting ducts and cause increased reabsorption of sodium. So once there's increased reabsorption of sodium, there will be sodium retention, which will lead to fluid retention, which will subsequently increase the volume of the blood. I hope you get it. And so that is how the renin-angiotensin aldosterone system works. Once it senses that there's a decreased volume of blood, it helps to increase the volume of sodium, and then as a result of where sodium goes, water goes, it also increases the volume of blood. Are you okay?
Okay. Thank you, madam.
All right.
Madam, there's a question in the chat also from ITEL S13.
I can't see the chat. I don't know why.
Okay, let me send it to you directly.
No, you can read it out and then.
Okay, madam, please, I want to ask. A lady told me 7 days after her menses, and she takes contraceptives. She bleeds again for another 7 days. Has it got to do with the same process? I think it was referral to something.
Hey.
Yeah, it has.
Hello, Nick.
Probably due to hormonal imbalance from the contraceptive. So it should be best serve by seeing a gynecologist.
Okay.
See what is going on with her.
Okay.
I realize that you guys like to take the opportunity to ask
Yes,
other
now.
issues. Yeah. So I wonder if you are able to do the lecture itself, if it has registered you, or once you hear something about you or something, then
You ask a question.
Yo, Nick.
So
Madam,
did you
a
understand?
kidney question. Madam, please, a kidney question, a nice question on renal physiology, madam. Madam, please, in the description you just gave, what of if during filtration, we've gotten to the tubular maximum of sodium? You know, sodium is actively transported. So what if we've reached its tubular maximum and none can be taken within the nephrons again? And maybe patients who are having excessive sodium within their plasma, their system, how then will this be feasible?
So this is not in the tubules, it's in the collecting ducts, which is the final place where
the distal.
Yes.
Okay, the distal tubule, the distal tubule.
So that one
can
still have reabsorption of sodium.
So, madam, reabsorption is also done in the collecting ducts?
Yes.
Okay. Thank you, madam. So, madam, that means that place there is no maximum level or for reabsorption or tubular secretion.
It can occur under hormonal stimulation. So the hormone aldosterone can change the dynamics so that you can still have reabsorption of sodium.
Okay, madam. Thank you, madam.
All right. Any other questions?
No, madam.
No, madam.
All right. So hopefully we'll have clinical methods to make up for what we did yesterday.
Yeah. So tomorrow morning at 8.
Yes. Hopefully.
Yes, hopefully.
Ejumanesi. I've been here, Afro.
So we are
Okay.
Thank you, madam.
All right.
We can end the session.
Yes, doc.
All right.
Thank you very much for your time, madam.
You're welcome.
Gentlemen, I'm still taking school fees, so I'm still on my school fees.
Master,